Hello, everyone. Hi. Welcome to the Doctor's Lounge. Alrighty, we have a host of physicians here. I just want to say that we had scheduled a webinar to talk about lower extremity vascular problems. And the physician that was going to host that particular webinar, she's going to do it next month. That's Dr. Warren. Karma Warren. And we're looking forward to that. She had an engagement that came up, something came up, and she couldn't change that. So we will have her on next month. All righty. But welcome to the Doctor's Lounge. What we're going to do today is we are going to talk about just uh, many different types of medical problems, and each one of us is going to grab something. Hopefully, we'll get through each one of us because the last time we did that, we only got through maybe about three of us, and the discussion got so good. But we're going to do that today. So, welcome, welcome. So, we're a group of, let me continue with my spiel. We're a group of Black physicians that are here for two reasons. Number one, to improve the health of people of African descent. Number two is to encourage young Black males to go into medicine because that is a key factor at this particular point. I will have to find this particular email that I got, that there are Black institutions out there that have scholarships for young Black men who are interested in medicine. And some of the scholarships, they're having problems filling the scholarships. And I will try to get that information before the webinar is up and give some more information on that. Alrighty. Um, this webinar is every second Saturday at 1 o'clock, of course. And please tell others about it because it takes a village to do something like this. It really does. So so proud that and happy that you out there who have joined so far that you're with us. Please text all your friends and everybody. Tell them that we're on, and they can come in as well and give them an idea on how to get into the webinar. All right. Thank you for OBHealthy for allowing us to bring this to you. And the most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Truly, only your doctor can best take care of you from a medical perspective. All righty. I'd like each of the doctors to introduce themselves. Dr. Kevin Clark, please start us off.
Good afternoon. I'm Dr. Kevin Clark. I'm a surgical oncologist. I work at Northwest Israel. Glad to be here today.
All right. Dr. Sprock, please.
Yeah, my name is Kendall Sprott. I'm a retired pediatrician. I did general pediatrics as well as critical care pediatrics.
All right. Thank you. Thank you. And Dr. Duncan.
Yes, hi, good afternoon, everybody. My name is Matt Duncan, current psychiatry resident at Ocean University Medical Center, down in Brick, New Jersey, finishing up residency and starting an addiction psychiatry residency at University of Pennsylvania in July.
All righty. Excellent. Excellent. And Dr. Garrison, please.
Good afternoon. My name is Jordan Garrison. I am a general surgeon and board certified in bariatric surgery as well as venous disorders and surgery.
All righty. And Dr. Court.
Good afternoon. My name is Dr. James Court. I'm a graduate of Howard University. My practice is located in East Orange. I'm an internist. I only treat adults.
All righty. All righty. And I'm Dr. Omar Bey, retired, believe it or not, pulmonary critical care physician. And now I am director of nutritional support for the ICU at Beth Israel Medical Center. All righty. So let's get started. Dr. Clark, Kevin Clark, I'm going to start off with you because, it's what Dr. Clark does is so important. He is very modest, I feel, but he is director of um, surgical oncology at Beth Israel Medical Center. And what he does, he treats some of the sickest and most fragile patients in the hospital. So I'm going to allow Kevin to go ahead and just give us some of your knowledge about what you do each day, number one, and Yeah, I'm just going to let you go ahead with that, brother.
All right. So, cancer is everybody knows somebody who's had cancer, or some people unfortunately have the personal experience with cancer. So it's something that's very important and touches everybody. Um, I think March is Colorectal Cancer Awareness Month, so I can focus it a little bit on colon cancer. And I think we've seen over the last few years a lot of disturbing headlines. Younger people, some celebrities who have had colon cancer, and it seems like people are getting cancer younger and younger and younger. We're not entirely sure what's the cause of that. It's hard to specifically pin down what exactly may be going on and is responsible for that. But certainly it's a disturbing trend that we've seen. We used to think of cancer, especially colon cancer, the recommendation was you start screening at 50. And actually, we started screening at 50 for a lot of things, for breast cancer, for colon cancer, because we thought at that point, or at least at that age, that was kind of the inflection point where your risk of cancer started to rise. And it was at that point where screening became effective and important to try to pick up cancer at a point where we can catch it early. And in some cases, when we screen, and I'll talk about it with colon cancer, you can actually prevent cancer. But similar to colon cancer, a lot of cancers, and breast is also included, we're seeing younger patients starting to present earlier with cancer. So that's something that's actively being studied. But as far as the exact etiology, that's something that's still to be discovered. So colon cancer, it affects quite a number of people. It's the third leading cancer incidence that we have, just behind prostate and lung in men, and breast and lung in women. So it's a significant problem. What's important with colon cancer is we can potentially prevent it. It's one of those diseases with early screening. Early and appropriate screening, I should say, we can potentially prevent it. So colon cancer develops over time, and it develops from a polyp. A polyp is a precancerous lesion that you can pick up on a colonoscopy and also other screening tests that can alert you that there may be a problem. With the colonoscopy, this is a procedure that's done where a camera is inserted from below and it looks at your entire colon, and it can detect these growths or these polyps, which are the precancerous lesions, and remove them. So when I mentioned prevention, if you remove these polyps, you will prevent the development of cancer. Now, one of the things, Dr. Ali is not here, but there's some polyps that we can see very easily and some polyps that we can't see very easily. So it's not 100% that, with the colonoscopy, that you can prevent all the cancers, because some of the polyps are flat and you can't necessarily see them to detect it. And the other tests besides the colonoscopy, there's something called a Cologuard test, or FIT testing. And that's a molecular test that it screens the stool to look for blood, and also to look for changes in the DNA that may be consistent with either polyps or cancer. So the screening recommendations now, if you have a family history, you start, and depending on when the earliest person who has the disease, you start 10 years earlier than what the recommended time frame is.
Mhm.
So now it's no longer 50, it's now 45 and 40. And if there's a documented family history of one of the known genetic conditions, screening could start in your teenage years. And that probably will change potentially it may change as we're seeing more and more younger patients get cancer. This age actually may even shift even more as we discover what the etiology may be because of this. With screening, again, if you pick up the polyps, you can remove them and potentially prevent the development of cancer. If you have been diagnosed with cancer, as with all cancers, the earlier you make the diagnosis, the earlier the stage, the better the outcome. We look at the treatment is based on the stage. So stage is another way of saying the extent. So if the cancer is localized, it's treatable. The cancer has spread, meaning if it's gone beyond the colon to other parts of the body, then that limits our ability to treat for cure. Now we can always treat, even when cancer has spread, we can always treat. But now the goal, depending on the extent, it may be curative or it may be what we call palliative. And even in palliative situations, sometimes that still involves surgery with a combination of chemotherapy and other modalities. I think we'll probably stop there. And
One thing I'd like to say is to the audience, please, if you have questions, please type your questions in. I hate to go through different topics and talk about different topics, and there are questions out there, and you really don't type your question in. Please type your questions in so we can know exactly what you're thinking. You know, if you have family members that you may want to get some more information on a particular topic, you know, this is so important to be educated about what we're talking about. Dr. Court, you have your hand up, please.
But Dr. Clark, can you please comment on the test called Cologuard? Well, how accurate it is, and what should we look out for? What should follow a Cologuard test?
so the recommendation for testing, you can either do the Cologuard test, which is a combination of looking for hemoglobin in the stool and also for abnormalities in the DNA in the specimen. So we know that tumor cells, we can screen for the existence of abnormal DNA fragments. And that could be a marker of either polyp or an actual tumor. So when you screen the stool, you do those molecular testing. That may be reflective of something going on. And that's a modality that you can do that in lieu of a colonoscopy. As long as it's normal, you repeat that every 2 to 3 years. If it's abnormal, that has to be followed up with a colonoscopy. If it's normal, then you can get another test in 2 to 3 years. As far as, so we know nothing is 100%, right? So you can still have false negatives. So a Cologuard test can be negative and you can still have the presence of either a polyp or cancer. The rates, from what I remember, it's pretty good in terms of the false negative rate. So the test is reliable in the sense that if you have a negative test, it's unlikely that it's missing either a polyp or small polyps it can miss, but it's unlikely that it's missing a large polyp or a cancer.
Okay. You mentioned several times false negative.
Yes.
And I think you've explained it, but explain it what false negative is for the audience.
So that means that the test comes up negative, but the disease is present. So that reflects on the accuracy of the test. We like tests to be able to be sensitive and specific. So if the disease is present, the likelihood of the test picking up the disease is high. That's sensitivity. If you test negative, we like to make sure that it's a true negative, and that's specificity, meaning that the testing won't miss the presence of the disease. So we evaluate tests based on their specificity, I can hardly say it, and sensitivity. And nothing really approaches 100%, but the closer to that, the better the test.
Excellent, excellent. Dr.
Gold
Garrison,
standard.
your hand. I'm sorry. Go ahead, Dr. Court.
The gold standard, what should you do? Which is the best test for that?
So I think People, you could do either or, but I think the gold standard, I think, still remains colonoscopy.
Okay, excellent. Dr. Garrison, please.
Yeah, they say common things occur commonly. And so, Kevin, this might be, below, this question might be a little bit below your pay grade, but I'm going to throw it out there anyway. Constipation.
Yes.
As people have gotten older, they get older, they're constipated. Um, and so I want you, what is your approach to constipation? And the second, to segue is, when do you recommend a colonoscopy? I've had an auntie who was constipated and they did a colonoscopy on her. They didn't get all the way to the cecal, and she ended up with a cecal carcinoma eventually. So, what is your approach to constipation, and when do you make the decision that this is just not constipation, but it might be an obstructing lesion in the colon?
Okay. That's a great question. Definitely not below my pay grade. So I think when you think of constipation, there are two aspects. One could be functional and one could be mechanical. So I'll take the mechanical one because that's easier. So it could be related to a physical barrier that's obstructing the passage of stool. And that physical barrier could be a stricture or it could be a mass. So one of the things that one of the presentations of
Kevin,
colon
could
cancer.
you explain stricture?
So stricture is a narrowing of that area. So instead of it being fully open, it constricts down. And that could be from inflammatory conditions, infectious conditions, or it could be from a mass or a cancer. Our job, well, my focus mainly is on making sure that there isn't a malignancy there to treat related to constipation. So constipation, if you have difficulty passing stool, we have to make sure by default that it's not related to something mechanical. And you mentioned doing a colonoscopy. The best way to evaluate that is to take a direct look with the camera or the colonoscopy. Now, in cases where you do have a blockage or a stricture and you are constipated, when there's difficulty in passing stool, you're also going to have difficulty visualizing the entire colon on the colonoscopy. So it's not unusual for situations to arise where a patient presents with constipation and the colon is filled with stool, and it's difficult to see a lot. So that's one of the limitations. Again, and we spoke about tests not being 100%. There's always limitations to what the test can pick up. Now, if somebody has that presentation and there's difficulty of visualizing the entire colon, that colonoscopy has to be repeated. Because you have to ensure that you're not missing something that's present. So they need to be re-prepped again. And that colonoscopy has to be repeated so you see the entire colon and demonstrate that there isn't any physical or mechanical cause for that constipation or obstruction. Now, the other part, the functional part of constipation is way, way, way more complicated. There are functional GI disorders that's a subject I wish Dr. Ali was here. That's a whole other subject where your colon itself doesn't contract as well. There are neurologic conditions that can cause that. And there's a whole bunch of things medical-wise that can cause that. But the first thing we always like to do, at least from my perspective, is to make sure it's not a mechanical cause and specifically a colon cancer causing that.
Thank you. Thank you. Appreciate it.
Patient comes to you with constipation, doctor. Do you advise a colonoscopy? And how many days after not having a bowel movement are you likely to say a patient is constipated? or it depends on their pattern?
So, right, so it depends on their pattern. I mean, some people go 1 to 2 times a day. Some people go 1 to 3. Well, it what's normal, it varies to some degree, but I get concerned when there's a change from their pattern. So you ask them what their normal habit is, and then what's changed. And if there's a huge variation, then you get concerned. Now, if they haven't had a colonoscopy, they're of age, then they should get a colonoscopy, irrespective, just for screening purposes. If there's a significant variation from their baseline, then that should also prompt potential endoscopic evaluation. Typically, these patients, what I most commonly see is not so much the problems in the colon, but the problems in the rectum. And the rectum is the lower part of the intestine. So patients will be more symptomatic from rectal cancers than necessarily from colon cancers.
Asymptomatic, what do you mean? Yeah,
Meaning that they'll have difficulty or pain on defecation. They'll have bleeding. A lot of times cancers, especially in the rectum, will present with rectal bleeding. Most likely intermittent, not profuse bleeding, but intermittent. So what you'll see is if you're seeing blood in the toilet after you have a bowel movement, that's of concern, as opposed to when you wipe. Again, it's not a general rule, but when you wipe, it's usually lower anal disease, which also could be a cancer, but most likely from hemorrhoidal disease. Versus if you actually see blood in the bowl, then you have to be concerned that it's a lesion high up.
We can't hear you, Omar. You're on mute.
You're mute, Omar.
All right, I'm on mute. Dr. Sprott, sorry, I was on mute.
Yeah, constipation is a fairly common problem in children, and also in adults, but in children. So what I'd like to do is start out by saying sort of the normal process of what happens. When you ingest food, the food, comes in through the mouth, goes in to the stomach. There's acid that's produced in the stomach that helps to break it down. And then shortly thereafter, there are enzymes which are designed to break up some of the foods that are there. So there's and enzymes are, they end in, the word ends in ASC. So there's a lipase, which means that the enzyme helps to break down fat or lipids. But there are a lot of pancreatic enzymes, which means that they come from the pancreas, that enter into the first part of the small intestine that helps to break things down. Now, it depends upon what you eat and the quantity that you eat in terms of what then happens, because what happens is that once it enters into the intestine, there's movement of the digested or partially digested foods as it moves from the lower intestine to the large intestine. And what happens is that there's a muscular layer around the opening of the GI tract that contracts. And that rhythmic contraction causes the partially digested food to go on down. And once it reaches the large intestine, what then happens is that water starts to be extracted from the stool that's entered into it. And once it's in the large intestine, there's almost a continuous absorption of the water that's in the gut. Now, there are certain types of things, we talk about fiber, or certain kinds of things that are not digested. And if those things are not digested, something like, that, and some of the fibrous things contain what's called cellulose. OSE means a sugar, but it's a type of thing that's not digested. And if it's not digested, it stays in the gut and it obligates water to stay with it. So if there's more water in your stool, the stools are softer. If there's less water in the stool, then the stool becomes drier and harder. And so in children, when the food gets down to the rectum and the anus, as that area starts to fill with the undigested or the digested food, there's an urge that occurs to defecate, and then you have a bowel movement. Now, if you have a situation where, and Kevin mentioned several things, but one of the issues is that there may be a low fiber content, which will mean that the stool will have less water and might become hard. It may be uncomfortable for the child if they pass a stool that's dry and hard. And what happens if it's uncomfortable for them, ultimately, what goes in has to come out, but they'll pass a stool that's hard. And once they pass it, it might be a large stool. And if you were to look at the stool itself, you'll see that the hardest part is going to be the initial part that comes out. And the stool that follows is going to be less hard because it has more water and it gets softer. Mm-hmm. But what happens if that child passes a stool that's hard and uncomfortable? The next time that rectum fills, they will anticipate that it's going to be uncomfortable and they'll not want to pass the stool, even though they feel the urge to. And that stool will become hard and dry. And you create sort of this vicious pattern of the rectum fills. It's anticipated that it's going to be hard to pass. They don't go. And then you develop this vicious cycle where they might wait a day or so, and then they have to go, and then they pass this large stool. So one of the things that you can do is you can give children something like, I'll say a type of laxative, if you will, which will cause them to have a bowel movement. And in general, these laxatives will do one or two things that you might try. One is it might contain something, a type of sugar that's not absorbed, that will obligate water, that will make the stool soft. Now, part of the problem with that is if indeed they have hard stool in their rectum, the laxative or the stool softener, if you will, and again, they're fibrous things that you can get, Metamucil and all sorts of products that don't have the ability to get absorbed, that will make it. But you'll start to affect the stool that occurs with the food that you eat, not the undigested food or the digested food that's in the rectum. So you have to get them to pass that. And then they need to be taking either a high fiber diet or one of these laxatives that obligate water, and then they need to pass it. Now, the first time that happens, that'll be good, but the child still may anticipate that it's going to be difficult. And so what you need to do is to continue to give it. And in children that have this vicious cycle of constipation, it may take several months for it to get completely dealt with. In the meantime, you might need to give, add prune juice, which acts as both a stool softener, if you will, and also kind of speeds up the amount of time it takes for the food to get to the gut. But what you then need to have, once the child starts to experience the fact that they're always having a soft bowel movement, you need to continue it. Because over that time that they've had these delayed bowel movements, that rectal tone or the size of the rectum has enlarged because of that constant presence of a large amount of stool. So you want them to start to have softer stools over a long amount of time, such that that rectal tone comes back to normal. And then you can say they no longer have the issue, but you still need to make sure that they have a diet that is rich in fiber. And things that like kale, and you have a better array of some of the nutrients that you might have that might increase it. But if you think about it, the major issue, it might be how fast the food is moving through the gut. If it's moving through the gut slow, then that means that water is going to be extracted from the stool, especially in the colon, and it's going to make the stool hard and dry. There's certain types of drugs. Okay. Now, we went through and still are experiencing, especially a large number of individuals because of pain, were on opioids. Opioids are notorious for slowing down the speed of the gut and universally leads to constipation. Okay. When I was a resident in training, we had a large number of babies that were being born to mothers that had addicted to heroin. And so sometimes that heroin would pass on to the kids and kids would have withdrawal. And sometimes we would give them tincture of opium called paregoric, which was designed to slow down the gut and also help to deal with the, I'll say, the withdrawal from the addiction that they were. But that universally caused them to have constipation. So if you think about opioids, and again, a lot of folks are on oxycodone and oxycontin and all those other types of drugs, a strong association with constipation that people had to and continue to have to deal with. And another issue also is that the neurologic innervation of the gut might be impaired, especially in conditions like diabetes, where there's an issue with the damage to the nerves that might occur with nerves that go to the gut that also might slow down the gut, leading to a lot more withdrawal of water from the stool and a lot more dryness. So, indeed, the issue is, well, what's normal? And what's normal may vary, but for a pediatrician, it's not the frequency so much, but it's the consistency of the stool. If someone, and again, we have this issue, in babies, if they're breastfed, they're on breast milk, okay? And the breast milk fed babies have very, very soft stools. We call it the consistency of uncooked scrambled eggs. And initially, when they first have bowel movements, they might have a bowel movement 6 times a day. And the deal is that they have the breast milk, and as soon as they have the breast milk, they defecate. And they're having the breast milk feed every 3 hours or so, and so they have that many stools. But something tends to happen maybe around 3 to 4 weeks of age, where even though they're still on breast milk exclusively, the frequency that they have stools much, much longer. Once a week, once in 10 days. And so the frequency goes down, but when they go, it's a large stool of the same consistency. They go blub, 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 the stool. And then they go blub, 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 the stool. And then they might go another 7 days before they have another bowel movement. But that stool is nice and soft and is easy to pass.
Right.
But if the stool that you're passing is hard and dry, that indicates that there's a problem. And again, if you think about what I said before, if that stool sits in the rectum and is hard, it may compress the water that's coming into the urinary bladder from the kidneys. And sometimes it will cause the bladder not to empty fully. And so very often you may have a situation where constipation might lead to urinary retention, which may lead to a urinary tract infection. So I think it's important for folks to understand. And again, in pediatrics, if you are constipated, you very often might have a little tear from passing a hard stool that might lead to a little bit of blood that doesn't have anything to do with cancer. And again, in older individuals, hemorrhoids is fairly common, might also have the same kind of issue. But I think the concern of constipation is, what kind of the type of food, high fiber, low fiber, or the speed with which things are moving through the gut.
Right.
If it's moving slowly, and it could be for either medications that might cause the stool to move slowly, or it might be related to that you're eating foods that are low in fiber and it moves slowly. But you ought to look at what it is and then what you might do to correct it.
Excellent, excellent. Now, Dr. Garrison, your hand is up. There's quite a few. Let me do this real quick. Dr. Aluya, Dr. Aluya, just introduce yourself, please, because you'd come in late.
Yes, sorry, I came on. Nelson Aluya, Medicine Pediatrics, currently the interim Chief Medical Officer for St. James Health in the Ironbound area in Newark, New Jersey, an attending physician at Newark Beth, and director of Alliance Rehab Center in Irvington, New Jersey. It's a pleasure to be here as always.
All right, thank you, thank you. Dr. Garrison, your hand was up,
Yeah,
and
I'm
what I
not.
want to do is I want to see if our questions can kind of stay short.
Yeah,
Our answers can kind of stay short because we got quite a few questions I want to get to as quickly as possible. Go ahead, Jared.
yeah. I just kind of wanted to circle back because Dr. Clark started this discussion
Mm-hmm.
regarding uh, colon cancers or malignancies.
Mm-hmm.
And, I just wanted to make sure that folks know the telltale signs or the things that would raise our suspicions or tell you as a patient that you need to follow up with a doctor. Recently I had a friend of mine whose wife was having bright red blood per rectum. And, she's in her 50s. The number one cause of bleeding in a 50-year-old or constipation is cancer. So what are the things that it would show? What are the symptoms? Well, bright red blood. Also, black tarry stools can be a part of a cancer. Um, One of the things that's interesting is if a 60-year-old man comes in with a sudden onset of an inguinal hernia, that is one of the things that they need to have a colonoscopy because the increased pressure that they must use to move a stool through is causes a hernia to appear. The hernia has been there since birth, but it causes it to appear. So that's just one of the small tidbits of trivia that we learn that can help save a life. But the key ingredient when we deal with a patient as surgeons in somebody with constipation is hydration. Are you drinking enough water? And there's so many benefits that we know now about hydration, hydration, hydration. And that's the first intervention we'd say is how much water are you drinking and are you drinking enough? And let's increase it. The use of laxatives, it's a double-edged sword. Yes, it can get you moving your bowels, but they have addictive potential. Not like you're going to be a drug addict, but your bowels won't move unless you take these other interventions. So hydration, and as Dr. Sprott said, a high fiber diet would help out with increasing the bulkiness and the softness of the stool to get it out. That's all.
Excellent, excellent. Dr. Court, your hands up.
Yes, for Dr. Clark. Patient who has not had a bowel movement for 4 or 5 days, what's the approach? Is it a stool softener or a laxative or an enema?
Um,
Hydration.
We
that
frequently
depends.
ask we frequently ask to give
Well,
them a stool softener, but they haven't had a bowel movement for 4 or 5 days.
so typically the ones that I'm seeing, is it somebody in the hospital or somebody that's an outpatient? Because
Preferably in the hospital.
um,
In the hospital.
in the hospital. If their abdominal exam, and the thing is, it kind of has to be taken into context. The other thing that can cause this is a bowel obstruction. And a bowel obstruction is when, in addition to being constipated and having difficulty, it could get to the point where nothing can pass at all, stool, liquid, or gas. And that becomes a surgical emergency. So the first thing we're going to do is to make sure and ensure that this is not a bowel obstruction versus constipation. Because if you try to facilitate stool passage in somebody who's obstructed, that's a recipe for disaster.
Right.
So that's kind of, we have to evaluate to make sure this is not an obstruction first. In the patient who's ambulatory, this is probably the more common scenario that's having difficulty. I think the process, you start off, as mentioned before, hydration, stool softeners. The point where you get to an enema, that's when those other things don't work. But I think you have to make sure you're not dealing with an intestinal obstruction first. Then you, in a stepwise fashion, you could do stool softeners, and then an enema probably is towards the end when other things aren't working.
Yeah. Now, Dr. Sprout, your hands up. I
Yes.
really want to get to these questions, though.
Yeah,
Go ahead.
it'll be brief. So the one of the things that we do in pediatrics is use a local lubricant. We use a glycerin suppository. And just that stimulation alone in kids very often helps to pass. But one of the things as a physician, and it's important, maybe people don't like to do it, is to use a glove that has lubricant on it and then go in and actually see what the stool is like. And sometimes when you do that, you can actually remove that hard part that then will help the patient to go. And again, once that initial hard part passes, it's easier for the rest to go. But sometimes a local lubricant like that. And then the other thing sometimes is not the stool softener, but some GI irritants like castor oil and things like that that can also stimulate the gut to push things through faster.
All righty. We have some questions that I want to tackle. I know Dr. Garrison is answering the question, but Doctor, I want you to answer it out loud so others can. The question was about lymphedema and the lower extremity swelling and what they can do about this. I know there are a lot of our sisters out there that get the swelling in the lower extremities, and they go to their doctor, and the doctor gives them this fancy name called lymphedema. Jordan, can you explain it? And are there any effective treatments for lymphedema? If you can, if you.
Oh, so you want me to talk about our president, huh? Okay. And those
I'm
cankles.
not going. I'm not going there.
Yeah, but that's a great example of what this question is referring to. And I'm going to kind of take a little bit of a trip to make it clear. Uh, in the leg, there are three systems of fluid. One is arteries, which brings blood into the leg, and two is the veins that bring the blood out. Now, when the venous system gets overwhelmed, then the lymphatic system kicks in to take care of that excess fluid. So
Hey,
that is
Jordan, could you just describe the lymphatic system? I think most people know about arteries and veins, but not so much about the lymphatic system and how it's in when it's normal, it's in equilibrium.
right. Again, it's in equilibrium, and that's because the veins are taking care of the fluid removal. The lymphatics it's like pipes or wires. If you look at something, you're going to have three different wires, three different pipes, and the lymphatic system has uh, channels, and then they have lymph nodes, which the channels run into. The lymph nodes are sort of like the sewer system of the body. They trap bacteria, they trap the debris that might be liquefied, and those lymph nodes will trap it in there. They also trap cancers. So when we do examinations and they say, oh, you got lymphadenopathy or swelling on the lymph nodes. And Kendall, you probably see this a lot as a pediatrician because these viral illnesses, upper respiratory viral illnesses, one of the things you do is you examine the neck and you're seeing all these lymph nodes in the neck and the shoulder and the anterior shoulder areas and things like that. So what is lymphedema? Lymphedema, a primary problem, most commonly caused by overrunning of the venous system. And therefore you have this excess amount of fluid that has to be brought out. What can cause overrunning of the venous system? Simply obesity can cause it because you have back pressure on the veins and the fluid can't come out. So it's backing up through the veins and leaking into the tissues, and therefore the lymph system is taking that. Now, when the lymph system is overburdened, then you're going to get what is called lymphedema. So my initial evaluation with somebody with lymphedema is one, there's other things that can cause it. It's if you have a protein deficiency, is to check labs. And I think one of the questions in coming up is about the routine laboratory exams. So
Yeah.
that would be one thing you're going to look at. You're going to look at the protein levels. And then you're going to look at what's going on in the leg in regards to, do we have venous obstruction? Do we have venous reflux? And if those are there, then you address that. Now, there is a situation where the lymphatics, there are problems with the lymphatic system, even though the veins are normal. And so there are some, to go direct to that question, after you've evaluated and corrected all the other things, there are some procedures that that have been done, surgical procedures, where you can take a lymph system and connect it to the venous system to help get the fluid out. A lot of people with lymphedema, I would say the majority is caused by venous obstruction of venous backflow, and simple things like wearing compression stockings. The other simple thing is to lose weight. And we're not going to go into weight reduction here, but losing significant 20, 30 pounds of weight will prevent the backing of the fluid into the legs and allow it to egress out in a very easy manner. So compression stockings. There are pumps that you can use to help prevent that from occurring, or once it occurs. But what we typically see are these very, very large legs. They can be called elephantiasis. So somebody talked about parasites in one of the questions. Well, there are parasitic diseases that can cause overrunning of the lymphatic system. We don't see that here in the United States, but it has started to pick up in the Southwest United States because of a lot of immigrations and a lot of parasitic diseases that come with that immigration. But typically, we're going to see this in Africa. We're going to see it in countries that are malnourished, and those, type of situations. And elimination of the worms or the parasites can help with the lymphatic problem. So our infectious disease people would take care of that. But one of the major operations in India, for instance, is resection of what is called the lymphocele, or a big balloon type structure that fills up with lymphatic fluid. And it usually occurs in the testicles and the labia majora from these, I think it's schistosomiasis, that causes that problem in these underdeveloped countries. So briefly, there is some things that you can do, but it is a chronic condition, and the results from dealing with lymphedema are varied and sometimes very dismal in the treatment of it.
Right. Thank you. Very good, Jordan. Very good. Dr. Sprott, you got your hand up?
Yeah. I think the question talked about lymphedema, and I think the real issue is whether or not it's lymphedema or just edema, because I think that when we talk about edema, there's a certain amount of fluid that surrounds the cells in the body that's normal, and that fluid is created on the arterial side of the circulatory system, and then it's reabsorbed on the venous side, and that occurs primarily because of the presence of albumin, the protein that Jordan said is what there's a total protein in albumin. Albumin is the main thing, and it's comes in through the diet and also produced by the liver. But if the albumin is low, then that sort of inhibits the ability of the interstitial fluid, the fluid that's surrounding the cells, to come back to the venous side. And if it's failing to come back to the venous side, then the interstitial fluid becomes larger, and then you have edema. If the edema is on the lower extremities, you call that edema that's dependent because you're upright. And so the issue when you're talking about the amount of interstitial fluid, if there's an increase in the interstitial fluid, we call that edema. Either there's an increase in production, and that could be localized because of an increase in arterial flow, like in the lungs. So you can have pulmonary edema because of an increase in the flow and pressure that causes creation of interstitial fluid that then doesn't get to come back. Or it could be a decrease in the return. And so the decrease in return could be because of low protein in the blood, or it also could be because there's an issue in terms of the loss of albumin. via the kidney. So some people that have kidney disease have low albumins, and with low albumins, you'll have an increase in interstitial fluid and edema. And part of what is described is that some of the interstitial fluid is taken back into the arterial circulation via the lymphatic system, which he talked about the pipeways that happens. And so if you have venous obstruction, either mechanical venous obstruction, or I call it functional venous obstruction, if you have the right side of the heart that's failed, you can have edema that occurs because there's a backup in pressure and there's a backup of the fluid, including the fluid that surrounds the cells in the venous system, and there's edema. The other thing that could happen with heart disease is if the left side of the heart isn't working very well, and you say congestive heart failure, then when there's a decreased volume of blood leaving the heart, the kidneys perceive that there's a decrease in the intravascular volume of blood, and the patient starts to retain sodium and salt, which then causes retention of water. And so a lot of people that are retaining fluid because they have heart failure are usually treated partially for the heart failure by giving a diuretic, which removes some of the salt that was accumulated because the kidneys start to retain salt. The other thing is to cause the heart to pump better, which makes the kidneys believe that the volume is adequate. So when you talk about edema, it's not just the lymphedema. The lymph can get overwhelmed. There are lots of other causes that you have to be concerned with other than sort of mechanical obstruction.
Right, right. Yeah, there's many reasons for edema, types of edema, and I agree with that. I think that we're going to go into a little bit more detail next time when Dr. Warren comes in next week, because this is her specialty, that lower extremities and the vessels and the type of edema and, things like that and varicose veins. So we're definitely going to get in deep next month as far as that's concerned. Let's go to one of the questions right now. And this is a question that concerns, just basic labs. It says, my question, can we talk about a little bit about labs that are typically ordered during an annual visit primary to your primary care physician? Are there any additional labs that a patient should ask for, when they come to their doctor? I know we got primary care here. Dr. Luya, I think you come under that category. What
Yes,
about labs as far as coming to your doctor and doing your yearly visit, because they encourage, especially all patients, to come in and do your yearly visit. How do you approach that, number one? And when do you think that the lab should be broadened for try to diagnose even different diagnoses? I mean, do
right,
you automatically do it, or a sign has to, like come off in your brain, like, hey, I see this, I want to do some extra labs? Go ahead,
right.
give us an idea as far as that's concerned.
Right. So, well, thank you. And ideally, everybody ought to have their annual well visit. Everybody, whether you're a doctor, an engineer, or a lawyer, or even the president, you need to get your annual well. And that's when you spend 30 minutes with your doctor and discuss everything, basically, from the disease you have, the concerns you have, review your medications, everything. And then um, they'll go into some of the details of reconciling all the other medications that you've gotten from anywhere else. Because sometimes those medications can affect, how your body functions properly or not. So all of those things you can do in 30 minutes. Now, to the actual blood, in your annual, this blood lab test should be done to check um, how your kidney functions, how your liver functions, the risk for diabetes, lipids, cholesterol, everything. So taking it by one, you do your A1C, and these are the ones that are really very specific. But we'll go to the beginning. CBC, complete blood count. And what that means is it's going to check the blood count of your cells, of how your immune system looks or works. If your hemoglobin is normal, and they have ranges, and some ranges, depending on the sex of the individual and sometimes even the age as well. So, and sometimes, so discussing the blood to order can be based on the age and the sex of the individual. You understand? I'll go into details, but the very common ones for everybody will be the CBC, which we check your white count, all the levels of the immune system, and we check your hemoglobin level, and also can screen to see it can give us an insight into if you're bleeding or not, meaning they see where the MCV is and the RDW. We compare that, to give us an insight if you're bleeding or not. And then you now do the CMP, complete metabolic profile. That's
Mm-hmm.
where it will check for your kidney function, your liver function, and the rate at which the kidney is filtering, your blood. And then you can check your cholesterol. We check your lipid profile. We check the total cholesterol. You check the good cholesterol, which is the HDL. We check the bad cholesterol, which we call the LDL. And we check the triglycerides, and we'll do a ratio of them. This, based on average, everybody.
Mm-hmm.
Now you can also do the thyroid function test to make sure that the thyroid function, which is the organ right in the middle of the neck. Some people have goiter, if it's hyperfunctioning. So you also do that. And then you check the urine as well. Make sure that in the urine, you have no blood. They'll check the specific gravity of the urine, the type or the color of the urine. It will tell us if there's blood or if it's clear, if it's muddy. You understand? If it's dusky, any of those things. And then we'll check to make sure there's no blood, there's no protein, if there's plus or minus ketones, they'll also check if there's risk of infection as well. Sometimes you see the nitrites or leukocytes, if it's there or not. So that's the basic things that ideally everybody need to have. And then based on the age, if you're 18 and above, they tend to do what they call the hemoglobin A1C. Not necessarily in kids, unless there's a reason for it, right? Now, hemoglobin A1C is to check your diabetes status. So we can tell, and we've talked about this multiple times here, you could tell if you're no diabetes, meaning your A1C less than 5.7, or if it's 5.7 to about 7 with no symptoms, that puts you at borderline or pre-diabetes. And if it's 7 above, with or without symptoms, if you have diabetes. You understand? So we also check for vitamin D, especially those who live in the temporal region. And if you live in the United States, more so, people who live in the cold region. We're all cooked inside the house, no sun, and vitamin D tends to affect our cognitive status, the immune status, the bone function as well. So checking your vitamin D level is really, really important. So on average, that's what we do. Now for men, you now add a PSA, right, which is the prostatic specific antigen to screen for prostate cancer. That I do from everybody who's age 40. Some specifications say we do that 50. No, for my community, I do that age 40 because we see a whole lot more, than usual now. Now, if there are other reasons for me to do other stuff, I can add a few other things along with it as well. Now, for women, we also, one of the beauty of the where technology is going is that we now have the ability to screen for cancers as well. So for women, we do the CA-125 for ovarian cancer. And we've picked up a lot of things very easily. We also do CEA, which is embryonic antigen. That is to screen for colon cancer for both men and women as well. Now, on the average as well, I also screen for prostate cancer. We have a lot of people who, go around with prostate cancer, not prostate, pancreatic cancer. We have the CA19-9, that we do for that as well. Now, if there's a risk, depending on whether risk or not, if there's liver issues or if somebody had hepatitis C or B, you could also screen for alpha-fetoprotein, the tumor markers, that will also to check to make sure there's no liver issues as well. So these on the basic are the things that my approach towards blood tests. However, one of the things I also impress on our community, especially those who are of color, especially those who are West African descent, is the urine microalbumin. Because the first sign to show that the kidney is suffering from problem is if there's protein in the urine, the tiny, tiny protein that you can't see. I always tell people this. It's like if you drive your car to the clinic and you come outside and there's oil on the ground, it definitely means there's something wrong with your car. The very first sign to tell there's something wrong with the kidney is if there's positive microalbumin. So that's some of the that we can check, especially if you have high blood pressure or diabetes as well. It really gives us insight into that.
Excellent, excellent.
Can I interject
I,
real quick?
yeah,
Just real quick, because just 2 points. The issue with tumor markers, and we have to be careful. You do them not in everybody, but you do them in patients who are at high risk of having that disease. Because a lot of times, CA125, unfortunately, is not a sensitive tumor marker. Unfortunately, for ovarian cancer, we don't have a good screening modality. But in women who are high risk, we will utilize those things as well as an ultrasound. CEA, same thing with CEA. If you have cancer, it's a good marker to follow, but in and of itself, you can have a normal CEA and still have colon cancer. So it's not a reliable tool necessarily to use to screen.
Excellent, excellent. Dr. Sprock, I see that you have your hand up.
Yeah,
We got a million questions though,
yeah,
Dr. Sprock. Go ahead.
just one thing to add to the CBC, which is drawn in a purple tab too. The one thing I think is important when you get the complete blood count with the white count, you want a differential added to it, and you also will want a retic count because indeed, if the person happens to have anemia, which is a low hemoglobin, you want to know whether or not they're making new red cells with the retic count or they're not making new red cells. And it's all done on the same test. It's not going to cost anything more. It gives you a lot more information to get that differential, which usually has to be checked off by the physician and the retic count.
Excellent, excellent. What I'd like to do, okay, we're past our half point, so I'm going to do my half point spiel, and then when I come back, I'd like Dr. Duncan. We haven't had you say a word, so we're going to get you involved, and we're going to tackle these questions because we got a lot of questions to tackle. All righty, so first thing I'd like to do is let's all introduce ourselves again because there are probably people that came in after we introduced ourselves. Kevin, could you start us off, please?
Sure, Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel. Glad to be here.
All right, thank you. Thank you. Dr. Sprott?
Yes, I'm Kendall Sprott. I'm a retired pediatrician. I did both general pediatrics and critical care pediatrics.
All righty. Dr. Duncan?
Yes, good afternoon, everyone. Matt Duncan, current fourth-year psychiatry resident at Ocean University Medical Center, finishing that up, and then starting my addiction psychiatry fellowship at University of Pennsylvania in July.
Excellent, and glad to have you here, brother. Dr. Jordan Garrison.
Good afternoon, Jordan Garrison. I'm a board-certified general surgeon, vascular and venous surgeon, and bariatric surgeon. Welcome, and thanks for having me.
All righty. And Dr. Aluya, please.
Yeah, Nelson Aluya, Medicine Pediatrics. Is a pleasure to be here.
All righty, definitely. I'm Dr. Omar Bey, and goodness gracious, Director of Nutritional Support at Newark Beth Israel Medical Center's ICU, and I'm overjoyed to be here today. All righty. Everyone note that this webinar is every second Saturday of the month, and please, it takes a village, so let others know about it. I appreciate that. The number one thing I can say, and the most important thing I can say, is please do not change any aspect of your medical care until you consult your physician. Only your doctor truly can take care of you from a medical standpoint. And I thank OBHealthy for allowing us to bring this webinar to you. What I would like to do is, Dr. Duncan, we're gonna jump in. You know, I'm not sure exactly what you want to bring to the table, but I'm just gonna let you do it. And then after Dr. Duncan, I want to let everybody know we're gonna answer some questions. Go ahead, Dr. Duncan.
Okay, so you know, the one thing I actually wanted to just mention or talk about a little bit was continuing on with our talk from 2 months ago,
Mhm.
when we were talking about behavioral health, and the concept of community psychiatry. So the idea really is looking to, address, mental health early with regard to prevention, but also this being a collaborative effort. So it's not just hospitals. I mean, treatment really should be starting in the community. So uh, the importance of awareness when it comes to, mental health, yes. Um, Substance use, sure, but also the importance that there are other factors that really can affect health in general. So issues with housing scarcity, food insecurity, um, policies that are made, for example, with regard to pollution in certain areas, fresh water. These are all things that factor into not just mental health, but also overall health. And the importance of understanding that these variables are important too. So, as physicians, being aware of your population that you see and really using context. It can be very in some ways it's not helpful or it can even be antagonizing if we're now telling patients like, hey, your blood pressure or we were talking about hemoglobin A1C now is extremely high and giving them instructions that are not necessarily achievable. So if you're telling somebody to stop eating white rice and start eating quinoa, and they are getting the majority of their food from a food pantry, they may be very polite and say, okay, doc, appreciate it. But they're leaving that visit more demoralized than just say this guy doesn't know me and, is not helpful. So I think it's just important to kind of talk about that kind of strategy, and how helpful it can be in our communities here in the greater Newark area, especially in our brown and black communities as well.
Excellent, excellent. You know,
Question.
the thing of it is, Dr. Court, go ahead. I see you have your hand up. Go ahead.
I do. But Dr. Duncan, can you please explain to us this diagnosis that patients come to see me all the time? I suffer from anxiety. What is anxiety? How should we approach it?
Okay. So, anxiety is probably one of the most common diagnoses you can really have. Uh, the idea is there are several symptoms that can present, but really it is several things that you can talk about. So really feeling very, very and let's not use the word. So feeling extremely stressed and not knowing why, to the level where you can't function properly. So we're saying function like doing daily things, going out, going to work, actually missing events because of how intense this feeling of dread is. Um, with regard to anxiety, one of the things they talk about is having like racing thoughts. So I bring that up because if you talk about things like, for example, ADHD as well, there are a lot of symptoms that are shared between both diagnoses. And people will say that they have ADHD, and what's going on is that they have not addressed underlying anxiety. So, with anxiety and the importance of it is really
Hey, Jose, hold
making
on.
sure that it's addressed properly. Um, we
Yeah,
usually
hold on.
start first with psychotherapy or addressing environment, and then if you are wanting to talk about medication, first line is for maintenance would be antidepressants, so SSRIs, and then you'd be talking about other things for what we call breakthrough anxiety. So that could be medications such as hydroxyzine or Atarax, and then sometimes you can use things like propranolol to help with, for example, like performance anxiety because you're addressing physical manifestations, so like palpitations, for example.
So really quick,
I don't.
follow up on Dr. Court's question. We all have anxiety. When is it pathologic? And at what point, what's that inflection point where you would say, well, this now requires treatment versus counseling, et cetera?
Right. So that's what I was saying before, where we have a response to stressful situations where you can start to feel, start to sweat, or start to worry. When it becomes an issue is when things that you would do daily, you can't, or you're having trouble, getting places, or you're avoiding things. Like, if I have a patient who's coming there, like, I can't go to work right now because I am entirely too anxious to get out of my bed, or when I get to work, I'm super overwhelmed. I'm not getting specific tasks done, and I'm now in trouble with regard to my performance review. That's when it becomes a problem because it is actually affecting daily tasks, daily life kind of thing.
Oh, the patients I see, usually I don't have anything close to that. To me, what Dr. Clark just said is more as a response to a stressful situation. They can still
Hmm.
function, they still go to work, they don't hide or whatever it is. So, is there one particular symptom that can define uh, anxiety, quote unquote, that we see, where I can't deal with this stuff?
So that's what I mean is it's a range of symptoms, right? And when I say it's a range of symptoms, everything is relative to people. So if I'm if somebody comes to me and they're like, I'm super anxious, and I usually try to use a scale. So I'm like 0 being no anxiety, 10 being a lot, and they're saying I'm super anxious, and they say it's a 10 out of 6. So I'm like, okay, it's a 10 out of 6 now. Are you going to work? Yes, work is okay, but I'm kind of feeling anxious. All right, I get that. There are other people who would say, right now, or I have underlying anxiety all the time. However, it is at a level now where I cannot even get into the car to do things. I'm avoiding situations. That's It's relative to the person. Some people, with regard to specific stressful situations, they get up, they do what they need to do, they're able to manage it. Others, when they have, or it's relative to them, and that stressful situation is one where it's debilitating. I mean, that's when we're talking about use of medications. But intervention wise, the first thing that you would be talking about is one, are you able to change your environment or address it differently? And those kinds of things you would address in, for example, like psychotherapy, um, or talk therapy, initially.
Any physical symptoms that you should look for?
So that's what I was talking. Yes, it's relative, as in we talk about the umbrella of anxiety. So if you're talking about, for example, like a panic attack, which falls under anxiety, this would be sweating, shortness of breath, palpitations. What they actually call, and you'll see it in the DSM, will say like impending doom or feeling like you're having a heart attack. Some patients actually present with the symptoms of a heart attack and will have to be evaluated to rule that out. That's how real it feels. So again, like I said, it's a spectrum when we talk about anxiety. But those are things that you can see with somebody who is particularly having a specifically very anxious episode at that time. Um, and they can be distressing. Some can be distressing to some people and not to others.
Excellent.
Dr.
Excellent.
Louis, do you see, since we do the same thing, do you see many patients with quote unquote anxiety?
Yes, they do come in. Usually if you sit, with them and tease into it a little bit more, you will see the precipitating factor, what's causing the anxiety. If you do it well. However, some of them just have generalized anxiety, which is a diagnosis in its own, generalized anxiety disorder. And sometimes it comes mixed up with other factors, adjustment disorder with anxiety, meaning they lost their job or they lost a family member and all that. And they're anxious, but it's hard for them to adjust to it. So one of the symptoms they tell you is that sometimes, some chest pain or feeling of overwhelmness. Sometimes they tell you they have headache, and often enough, they tell you, oh, they can't sleep. They can't sleep well at night. So all of these things come up together. And you have some people with anxiety with depressive symptoms. So you just have to know which is which and how, and then tease in and refer accordingly to the appropriate specialist for care.
That
To me,
visit
it's more
sounds like it's
like
over
panic
now.
attacks. Mm. To me, it's more like panic attacks that they present
Yeah,
with.
yeah.
That they deem it's anxiety.
Yeah, yeah, possibly. Let's get to some of these questions. You had your hand up, Dr. Duncan.
Yeah, I just wanted to piggyback off that. So as I was saying before, anxiety is like an umbrella term. When you talk about panic attacks, that falls under the umbrella. So that is also falls under anxiety, right? What Dr. Lewis said as well, when some of these things tend to present together. So like somebody who's super anxious could be depressed as well. But with regard to addressing treatment, it's the same thing. First line would be an antidepressant. Well, first line medication would be an antidepressant, but psychotherapy would be really what you'd be looking to address first and seeing how a patient responds to that.
Excellent,
Very
excellent.
good.
All righty. Let's get to some questions here. First one is, can type 2 medications cause constant constipation? Um, Kevin, I don't know exactly if you can help us with this, or if Kendall.
Yeah,
You want to defer?
oh, go ahead. You want to go?
No, no.
Yeah,
I'm gonna defer.
we had a big discussion a few weeks ago about the GLP-1
Hmm.
medications. And again, people that have type 2 diabetes might be on a lot of different medications, but I think for the most part, they're talking about the new GLP-1s that are really related to trying to decrease weight loss, which often improves the hemoglobin A1Cs. They are fairly well known for causing constipation, usually by two different mechanisms. One is by delaying gastric emptying. That means that the food stays in the stomach longer. And the
Hmm.
second one has to do with the intestinal motility, how fast the gut contracts and moves it through. And so, what they talk about doing, if indeed you're going to be on one of these medications, is to do the things that we talked about before: increasing the amount of fiber in your diet, drinking, water 8 times a day, which I'm not so sure how good that is. But if you have the fiber along with increasing the water, that definitely can help. But yes, it's fairly common in if you take those kind of medications.
Right, right. Second question. I heard that getting rid of parasites in the pancreas can eliminate type 2 diabetes. Is this true? I know you're on Facebook a lot and you hear about this, the parasites this, parasites that. Anybody has any information as far as this is concerned, as far as type 2 diabetes are concerned? I know it's a little bit out of my reach to give a comment on this.
Well, I'll tell you this.
Dr. Sprott, I know you were going to come up
Yeah,
with it.
yeah, look. I think that I don't think there's any medical evidence to support parasites in the pancreas. Remember, a lot of the parasitic infections that you get, a lot of them come in via the GI tract, either because of issues related to food or water or things like that. Some parasites you can have on your skin. But, the pancreas is sort of an isolated organ, and its major function is excretory. That means it secretes pancreatic enzymes into the upper part of the intestine to help digest food. The pancreas is the organ that does have the cells that help to produce insulin. And so theoretically, if there was an issue it affected the pancreas, it might affect those cells. But for the most part, those cells make insulin. If you have type 2 diabetes, those cells make an inordinate amount of insulin.
Mm-hmm.
In the type 1 diabetes, those cells are destroyed or damaged, and so you can't make insulin. But the majority of people in this country that have diabetes, they're making an overabundance of insulin to try and control their blood sugar. And as they become more and more overweight and obese, it takes a larger and larger amount of insulin to try and keep the blood sugar within normal range. And at a certain point, even producing large amounts of insulin still are not able to control it, and therefore you get all the issues of the increased blood sugar and increase in hemoglobin A1C, and over time damage to small vessels that can cause issues related to loss of injury and retina and things like that. But to my knowledge, there is no association between diabetes and parasitic infection.
There's a lot of stuff on social media about that, but they don't name the parasite. What's the name of it? Where did it come from? How can it get into your pancreas?
Yeah, it's usually designed to take something that you have to pay for.
Yes.
Yep, yep. All righty. Next question. Besides taking Viagra or Cialis, what is the best way to dealing with erectile dysfunction? It's called Dr. George Johnson. Um, I know that internal medicine, Dr. Court, you probably sit down with gentlemen and get this question. How do you handle it? Where do you go with this problem?
You have to take something that increases the blood flow, because without blood flow into the corpus, you would not get erection. There has to be something that there's a lot of talk about beats on TV, and basically, what has to happen is all those substances, all those products like Cialis or Viagra. The problem is they tell the body to make nitric oxide, which is a vasodilator. And when the blood vessel dilates, there's more blood flow into the penis, and that would improve erection. It
Now,
should. Let's put it that way.
yeah, what about patients that are like sometimes with obesity or sometimes with diabetes? That it may be not just blood flow per se, it may be other ailments that are contributing, such as medications they may be taking,
That's right.
hypertensive medications, things like that. So, in a patient coming in, how do you evaluate that patient and give them guidance? When do they need to go to a urologist and have that type of workup, as opposed to maybe we need to change your blood pressure medication?
Well,
So if I may take this, so usually we see this all the time. A young guy comes in and says, "Oh, older or whatever age it is," and doc, um, I'm not having, good time in the bedroom area. Things are not working as it ought to. So first is to take a history. History will give you, physical will give you almost 80% of the diagnosis, and the lab 20%. And and that's the way to approach it. So you take a very good history. One, find out if whatever disease is dealing with, if he has, and two, if he does, what medication is he taking as well with it? Any history of trauma in the past, any history of infections as well, or any history of recreational medications he's taking. Because all of those things can truly affect that individual. And then you go on to you know find out if there are other confounding issues, meaning, again, we talked about depression, anxiety, and all that, and what situations. Now, including the fact that, hey, do you have early morning telomeres? What does that mean? Early morning erections. Every male in the morning gets an erection every morning. So if you don't have an erection every morning, then it's a little more organic than usual. But if you do have an erection in the morning, but then you have erectile dysfunction, either pre-ejaculation or you can't hold to sustain a penetration or any of those things, then you have to tease each one out to know exactly what it is. Now, going further, you go on to do the test, screen for diabetes, thyroid disease, any other disease that there are. And of course, you have reviewed the medications as well. If they started them on the individual new medication, the big culprit is beta blockers, especially metoprolol, can do that. Is there long-term use of steroids, if there is anything at all? Or has there been any chemotherapy use or any of those kind of stuff? Or even antipsychotics as well, you know? So, and then when you do the test, um, for males, I often also do outside of screening for diabetes and everything else, checking the urine and all, I will also screen for testosterone level. A lot of people tend to have low testosterone levels. In fact, somebody was actually saying some estrogen based, diet that a lot of people are eating these days that can affect, their sexual function. Um, and so you check the testosterone level, see if it's adequate. For a few, they've been really very low. I think the average ideally should be about 300 to 1,500 or 500 to 1,500. And some people run 200, 100. So for those individuals, they may have to do testosterone shots and see how it improves. You also check the um, what you call it now? There's a test um, to check for. Oh my God, I'm having a brain block. But oh my God, I remember.
Check,
But just to
to
make
check
sure
for what?
that you're not producing too much. What's this enzyme that affects the breast, lactation, and all that? Because sometimes some
Prolactin.
individuals.
Oxytocin?
Sorry?
Oxytocin?
No, no, no. Oh,
Prolactin?
I remember.
Oh,
Produced by the pituitary, it gets enlarged, and then oh my God, but I remember. But you screen for I do that all the time. So you screen for that because sometimes enlarged pituitary can actually suppress the chiasma, suppress the backflow to the adrenal that produces sex hormones as well. So all of those things, that's the approach I take to it.
Mm-hmm.
Yeah,
I think
just
also,
quickly, the niacin, which is vitamin B3, which is you talk about the nicotinic acid, is also been shown to possibly improve erectile dysfunction. Uh, After taking it, maybe could last for about 1 to 2 hours.
Mm-hmm. Mm-hmm. Excellent, excellent, excellent. Thanks,
I
Dr. Aluya.
was also told that the way you feel about your partner
Well,
is
that
a
too.
yes.
That is true.
You're going to get a whole lot of negative comments about that.
Well, and that's why I say situational.
A
Situational,
situation.
right? There you go. We have questions that pertain to the lymphedema. I know that Dr. Garrison had gone off, but maybe Dr. Sprock, you can broaden some of this. There are quite a few questions. I think the person who is talking about it had left several questions. I'm going to read them. Um, uh, be prevented. All right.
Can I just start?
Yeah, go ahead. Go ahead.
Yeah, just the one he asked about the swelling basically in the lower left leg.
Right.
And I think the issue when we talk about edema is whether or not it's generalized edema. That means that you have excess fluid throughout the body, or if it's localized. If it's localized, then you're usually talking about some kind of a mechanical obstruction. And
Mm-hmm.
again, it might be related to the issue of certain valves that are on sort of the left portion of or one the portion that you have the swelling. It could be venous problems that are there, or it could be certain kinds of obstruction, either to the venous flow or the lymphatic flow. So when you're talking about a localized edema, I think that it becomes important for you to try and figure out if there is an obstruction, where the obstruction is. And there might be some diagnostic tests that you might have to get in order to see where it is. But generalized edema, if you have an issue with, congestive heart failure, or you have an issue with low protein in the blood, that will usually give you a generalized edema and not just a localized edema.
Mm-hmm. Excellent, excellent. Um, and I know, Dr. Garrison, you just came back in. There were several questions as far as the lymphedema that we were talking about. One thing they had asked was that whether anyone knew of a physician that took
In
care of that
Queens,
in Queens, New York area. And I really don't know any of the docs over in that area if there's, because obviously this person wants to follow up with someone. Um, Dr. Garrison, do you know anyone in that area or could refer to a vein clinic possibly? Or you're on mute, you're on mute, Jordan.
Yeah. Metro Vein Center. There's there's an office in Queens you could
Mm-hmm.
go to. Metro Vein Centers. Okay.
All right.
And
What,
the initial consultation is free. Okay.
now, is there any role for a lymphedema pump? I think one of
Uh,
the clinics, I think at St. Barnabas has one of those.
yeah, there are several practices that specialize in lymphedema. I know Dr. Pappas in New Brunswick area. Um, there's a lymphedema clinic at St. Barnabas, and there's
Barnabas, yes,
also a
they do.
lymphedema clinic at Hackensack. But
Mm-hmm.
most of the vein centers, I would start off with the vein center first and get your evaluations and you get your ultrasounds and then because the problem may not be lymphatics, and
Mm-hmm.
so I would suggest as a starting point a vein center, and you can look them up online, vein centers. But I do know in Queens there is a Metro Vein Center,
Right.
um, and it's Dr. Lopresti, Dr.
Mm-hmm.
Phil Lopresti. Okay.
Right. I can also tell the person who's asking these questions is that Dr. Karma Warren next week will be here, and she actually does these. I think she does those type of evaluations.
Yeah, Dr. Warren and I have worked together at
Mhm,
Metro Vein Centers, and her office is in Bloomfield for
mhm,
Metro Vein. She also has one in Wayne, New Jersey. But
mhm.
Metro Vein Centers, Dr. Warren will be, you know, um, she's an excellent physician. She's
Yeah,
an excellent physician, and I think you'll get the the warm, homey side as well as the didactic clinical side, and she will not tell you anything wrong. Okay.
right, right. So please, tune in next month because she will be here, and she's our focused physician, talking about many things about the lower extremities, as well as her extensive years of practicing medicine in the inner city in emergency room, and she's going to cover a lot of topics for us.
Yeah, she's the real deal.
That she is. Um, there is something, one of them questions came in about AI and how AI is affecting how do we feel AI will affect medicine and what specialties it's going to affect. I know at this particular point, um, radiology, reading X-rays, CAT scans, MRIs, things like that. A lot of that is being taken over by computers and and AI. Um, is there any other?
Pathology,
I'm sorry.
pathology, reading the
Yeah,
slides,
yeah.
a lot better than the human eye.
Yeah, that's what I hear. Yeah. So, Kevin, do you hear anything that coming forward that physicians and actually more so than us that people out there, patients will have to, it's going to be a part of their medical care more so than it is today?
Okay, I think it's affecting everything. The question is, in what context is medical practice going to look like? I think radiology, certainly pathology. I think things where you can platform, you can put it into a computer process and they can look at it and examine it. It's a lot easier when you have to talk to patients. I mean, you can certainly put in symptoms, evaluate labs. A computer can't do a physical exam at this point, at least not that I'm aware of. So there's still certain things that you still need in-person kind of interactions to make a diagnosis, or at least a good diagnosis. Surgery at this point, I think it's not at the point where it's independent of somebody doing something. So we have robotic surgery, but it's kind of a it's not the robot doing the surgery, it's robot assisted. So we're still doing the surgery using the robot. So it's not autonomous. But certainly, that's in the future, things are gonna look different. It's just in what context. I think feels that you don't have a lot of direct interaction, or the complexity of the decision where it involves an examination or process that you have to interact with the patient. That's going to be a little bit harder for AI to, I think, take over.
Mm-hmm. Dr. Garrison, your hands up.
Yeah, I'd like to echo some things that, Kevin just said. At this point in time, there is no replacement for an actual physical exam. Where I see AI coming into utilization is in the diagnosis. Um, there's tons and tons of medical information and cases from the past that have been put in there. And sometimes there are these obscure diagnoses that just are beyond my bandwidth. I might have read about them in medical school, but have no personal experience or haven't seen it in clinical practice. And by putting certain information in and AI can spit it out. Have you considered this? Have you considered that? With all as medicine advances, it's not all good because AI can misdiagnose. It can send you down a path somewhere else. There's racial biases in AI. And Dr. Alua can speak to that, the racial biases that he sees in that patients that come in, and how they're diagnosed and treated by other physicians or the medical industry in itself. As regards to surgery, one of the things that you have to learn as you're doing robotic surgery is you lose the tactile sensation, the little fine nuances and stuff like that, where if I press on something, I can tell just by pressing on it what's going on in that piece of tissue and whether I need to approach it one way or the other. The robot, you lose that sensation. The robot does wonderful things. Eventually, like they have these meta glasses where they say, okay, meta, take this picture. I eventually think that type of technology will be coupled with robotics, but still, you're going to need a human operator to interact with the tissues and know what to do. Those little nuances are going to be necessary. We're not there yet. We're not at Star Trek level where it can take a camcorder or whatever that thing is, and it will fix your spleen from bleeding. We're not there yet. We may be centuries away, but it's coming.
Yeah, yeah. Dr. Duncan, I see your hand.
Sure, yeah. So I just wanted to talk from a psychiatry point of view. Um, I think that, with some of the technology out now for psychiatry, it can help with efficiency. So there are a couple recording specific AI apps that you can have on your phone to let the patient know that you are recording while having the patient encounter, and it can actually group your SOAP note accordingly. So I mean, the concept is very helpful. However, there are errors, and especially in psychiatry, it's very important if knowing, if somebody is on a very run-of-the-mill medication as compared to an antipsychotic, and the AI hears it differently, and you put that in your note and not check that, that's a problem. So, I mean, it's all fledgling in my opinion at this point, and it does not replace, the physician and, the core of what we do.
Excellent, excellent. Dr. Oluya.
Yes.
Sir.
So we need to know, the AI has been around us for a long, long, long time, way back in the 1940s. It's just now it's being integrated into a lot of things. And the integration of AI into our day-to-day lives, meaning non-military or security-based life, it's like when the internet was first formed and the cell phone was as huge as the whole house. So, but its application eventually will be on everything, everything. And you can imagine when, the cell phone first came out and all you could just do is call or whatever. And then they added text. And then they added, you know,
Think we're
pictures
frozen.
and
Okay.
camera future in its application in the future. Now, in terms of medicine, if you look at AI, and that's why we need to be careful. And when I speak to young doctors as well, I say, listen, in the future, you guys may need to know how to code. Because if you look at the auto industry, look at the cars that we drive, they're so complex. What makes those machines, those cars? Not human beings anymore. The bolts, every single thing within the car, it's basically done by robots. And these robots are AI now inspired, and they've been doing that for a long time. So they're going to apply that into medicine.
Mm-hmm. Mm-hmm.
And we've seen that in radiology, we've seen that in pathology. Guess what? Dermatology as well, where the AI, you take a picture of the skin rash, it gives you the right diagnosis, and everything is straight. Now, on into general medicine. So what's going to happen is you have, and they're doing it already. You have a camera, you stand in front of the camera, it checks your weight, your BMI, everything's calculated. AI spills the whole thing, prints it all out, boom. And in the future, it's going to connect with the lab, sense a single prick of blood. It analyzes it there and gives you the amount of salt in your body, the amount of salt that you need to eat in the next food. You're gonna scan the what do you call it? Everything you eat, you're gonna scan it before you eat it with the cold bar. Boom, you'll tell you the amount of salt, what you need to eat, how you need to eat. This is coming.
Mm-hmm.
There's no way around that. You understand? Stand in front of the camera, take your eye, tells you if you have retinopathy or not, the risk of you having myocardial infarction in the next 5, 10, 15 years. All of those are in process.
Yeah.
Now, what does that mean to us or to the patient? What I tell patients, now is this, and I think it's a good thing because I'll tell you why. When you compare AI to just general Google, when people Google stuff, it gives you almost the worst of the worst every time. Do you read? And you see patients coming, they're running to you, they're panicking, like, oh, it says cancer and all that. But if you learn to ask AI specific questions, AI will give you the specific answers and direct to you. But eventually, will tell you at the end of it all, at least for now, that you need to discuss this with your doctor. But they're really very specific, and it's getting better and better every day. So, what AI will do to the patient, it's it's empower the patient by giving them better understanding and better information that they will interpret at their level of reasoning. And that's the beauty of what AI will do.
Right, right. Thank you. Dr. Sprott.
Yeah, there's a lot that's going on in AI, and I just gave before this started a friend that passed that had some severe cardiac issues, and the last time he had been to the hospital, he went home with a tablet. That tablet had everything, monitored his oxygen saturation, everything else, and would transmit the information to the cardiologist and back to the cardiologist. And it would tell that if he had any kind of arrhythmias or he had anything, all of that's sort of going back and forth. But I wanted to ask a question to our psychiatrist. There are these artificial intelligent generated people that are in communication with people, live people. And there have been some cases where those individuals they've identified issues of concerns where the person has issues of self-injury, a possible suicide. And the AI didn't sort of generate to that individual that they ought to seek counsel. And there's a concern about those types of AI generated individuals that are communicating and influencing what people do or don't do. And the same thing may occur again as we talk about it, whether or not, as you talk about having artificial AI generated individuals, could be professionals that again could take over and take on these nuances. It's advancing very, very quickly. But as you said, Nelson, when my friend was in the hospital and I was trying to look at the treatments that he was getting and trying to give it, you'd ask a question and AI would say, took it to another degree. So heart failure with renal failure, and then decrease ejection fraction. And then they talked about a certain area, and I said it's lower than that. And then they came back with another information in terms of this and the way that various types of therapies could impact this. So I think that and I'm a physician, and it kept so with the initial question, it made me ask 4 different additional questions, and each time it gave me specific answers. So and it gives it right away. And so I think that one of the things that people will see is if they have questions and they ask these questions, and again, Google also has the AI response as well. They may ask you additional specific questions. I can tell you, Nelson, never did they ask me that should this stuff be discussed with the doctor. They just gave me the information.
Yeah, yeah. So the thing of it almost is, it's like chat, the chats that's out there. You almost have like a computer partner talking to you and giving you information. The information given back is only as good as the information put into the computer.
Right.
So, the thing of it is that, there should always be a question mark in my mind as far as
So
the information
th-
given
these
that,
things
that
are
we're receiving.
very right. So these things are very new yet, and for older folks like us, I'll use the word, we're still in the process of learning. Our kids and children and grandkids, this is what their life would look like,
Hmm.
and they'll be so used to it, and
Hmm.
they'll interact with these machines so perfectly. And guess what? Each one in the future will have their own chat boxes, and that's what it is. So the chat box that I use for my personal stuff understands me, knows me, and if I ask questions and say, "Oh, Dr. Luya, I'll do this the way you're used to doing it," because we interact with one another so often that it knows how I process, how I think about stuff. And sometimes
Nelson,
we
are you talking
get
about your wife?
that's another story. But you know what?
But Aluya, Dr. Aluya, that's a double-edged sword.
It is.
To me, that's a double-edged sword because if someone's giving me back what I always do or how I always present it, then I'm not learning, I'm not broadening, and it's just feeding me what I know already. The way I think about it, even in a conversation, if I'm sitting there
Right,
not and someone will say, well, why didn't you add to the conversation? I'll say, because I already know what I think.
right,
I want to know what he or she thinks.
right.
And if I'm dominating the conversation, guess what? I didn't find out what they thought, so that broadened my knowledge.
True. And
That's the double-edged sword.
That's why Dr. Duncan will continue to be in business. You know why? It would evolve into a different aspect of psychiatry where and psychiatry and neurology as well, because there's certain portions of the brain that you begin to lose function of those
Yep.
just by depending on AI. It is not the dependence, it's the utilization of AI. And people tend to forget that. It's not how you replace AI for your thinking, but utilize AI to achieve your aims. But
Mhm.
then you have AI, sections. I mean, I'm sure, Dr. God Duncan, you still you're still new, you're gonna come in and there'll be an AI evolved psychiatric aspect in the future. I know it's gonna come.
Mhm.
Does
Mhm.
anybody believe that
So,
any of this stuff isn't subject to the world knowing? You can't believe that any of this stuff is going to be private.
No.
Somebody's going to be trying to
right,
sell this information in order to make money off of you. And so I tend to not want to get
right.
involved in those kinds of aspects because someone's analyzing it, trying to figure out how they can sell me something.
Mhm. Mhm. True. 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 True.
So,
Just like just like your email. Yeah. AI can now situate your email. I
right.
don't want to update my computer because I don't want AI in my email. So I still have the old processing system. I'm all like, oh man, this is crazy.
Omar, I just have one question to ask Dr. Duncan, and it really came from
Hmm.
Dr. Court's question.
Hmm.
You know, I don't know how a physician can tell whether or not someone that comes in for anxiety really has anxiety, or whether or not they're looking for medications that they might want to help them calm down or might possibly be looking to abuse.
Hmm.
How do you try and sort that out?
Great question. I still can't figure it out.
No,
What they're
I
trying to
was talking
do.
to our psychiatrist friend.
Yes,
Okay.
I know. I know.
So
You gotta
I mean
speak.
that's a great question,
Yes.
right? That's a great question. As in if somebody's coming because they are looking, looking for medications. So I'm assuming you're talking about patients who may be wanting to come in and be getting something like benzodiazepines, for example,
Yeah.
for
Yes.
anxiety.
That's the most common.
So,
And sometimes
that's the
they ask
first.
by name.
Mhm.
Yes, so it'd be Valium or Ativan, or I mean, most popular one would be Xanax. Really, it's context. So especially for psychiatrists, we are always wanting to understand what is your level of anxiety and what is the dysfunction that's going on.
And how much
I
time do you
think
have
that
to do
it's,
this?
I'm sorry.
And how much time do you have to do this? 25 minutes?
If you
Well,
only
I
about
mean,
5 minutes.
well, that's so what I would say is that an intake usually is like between half an hour and 45 minutes for us, but it's certainly something that you would have to do faster depending on how many patients you're seeing. It is different in, primary care where you seeing people for much less time. So that's a great point. But with our specialty, we do tend to take some more time with patients to tease out whether in fact it is appropriate to start medication or not. Um, but I don't think there's a simple answer for that, except that it depends context wise and by patient, honestly. But am I just going to throw a Xanax at a patient just because they are saying that they are anxious? I mean, that's not first line. First line would be, maintenance wise for medication would be antidepressants.
Excellent. Dr. Garrison, your hand's up.
Yeah, I guess this is a comment and then a question. Um, I think the end result, what Dr. Duncan is seeing, is the anxiety. But what goes on before that? My belief is that our society has gotten soft. I mean, the normal things that happen in a day, they 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 can bother you. They create some anxiety. Sometimes I'm driving down the road and people are driving crazy. That can create anxiety. Does that mean that how do you deal with that? What is the root cause of that heightened anxiety? I think our society has come to this point where we think that everything should be this nice, smooth, and I should make more money than my parents. My mortgage should be this. I should be able to do that. I shouldn't have any hardships in my life. And my opinion, a lot of the patients that I see that come in with anxiety is just that them dealing with everyday life and their expectations are off. Not necessarily that their physiology is off. The physiology is a result of the expectations. So, Dr. Duncan, in that me saying that, when you if I have 100 patients coming in anxiety, which ones of them really have a primary physiologic problem, or is this a secondary result of dealing with life stresses and belief that, well, everything should go away or there's a pill that can fix it?
Okay, so the first thing I would say is, generation wise, you have to factor in variables. So one of the things now is we're on social media right now. We're on Facebook Live. You get information bombarded in your face from the time that you wake up until you go to sleep. And even when you're sleeping, if your phone is on, you're hearing it ding. That is causing anxiety. You going on different like social media websites and seeing people you went to high school with, or people going on vacation, and the term is very sad smiling faces. So everybody is showing that they're doing super well, but they may not be. But to you, you are wondering why you're not doing that well. That is going to cause anxiety. I'm saying that to say, we talk about physical manifestation, and then also or that you have potential physical manifestations from anxiety, but in the mental health realm, I mean, if you're feeling particularly depressed or you're feeling particularly anxious, you can have a feeling of feeling overwhelmed or not being able to think straight, etc. These are also symptoms of anxiety. They don't necessarily have to see them manifest physically. What I would tell you is it's very difficult to compare one generation to another, and just because I'm kind of in the middle, because I'm an older millennial, uh, a lot of things that even for us when we were in high school and what goes on now with these kids, there's a level of expectation and everything is shared now that I don't feel half the people that when I was in high school could handle. So it's difficult to say, and that's why I really want to emphasize it really is a case by case or patient by patient basis. It's not cookie cutter. I can sit here and tell you like these are first line things that you can do, but there are some patients that are so particularly anxious that in fact, yes, maybe using a longer half-life benzodiazepine to bridge maintenance medication that would be, you know, an SSRI like Zoloft would be appropriate. But it really is something that you have to tease out. I couldn't say this is definite and this is definite. That's not, unfortunately, that's not how we can, you know, really approach anxiety in our community or depression in our community.
Dr. Duncan, would you necessarily have to say this person is unable to function before you change the diagnosis of anxiety? You have to have that?
No,
You
no.
don't, you don't.
And when I say unable to function, I mean that's a spectrum of things. If they are so anxious before an exam that they fail the exam because they can't study, as compared to they're so anxious that they're staying in their house. I mean, those are two examples of not being able to function or do daily things. So in both of those situations, you are going to want to address that. Maybe one is psychotherapy and then the other one is medication, or maybe it's both. So I mean, I'm trying to explain like people can get stressed. We are humans, so we do get stressed in certain situations and we react differently. Some people are able to, it just rolls off their back like a duck on water. And then for others, it can be super debilitating.
Dr.
I think that
Aluya?
the term disorder sort of has the common theme about interfering with your daily operational. And so it's a spectrum. Everyone has a bit of obsessive compulsiveness, especially if you're a physician. The question is, how obsessive compulsive are you that whatever it is you're doing, washing your hands or doing this, it interferes with your ability to accomplish what you want to accomplish in a day. And for different individuals, it's very, very variable. But I think that to Jordan's thing, Nelson and I and Omar, for the most part, practice medicine in Newark. I did pediatrics. The majority of my patients were single mothers. A lot of them had low-paying jobs. Some of them were on TANF, temporary aid to needy families. A lot of them had experienced violence. A lot of them had experienced things, and their cycles repeated themselves in terms of their mothers, same thing. So, when you talk about society fixing things, society could fix a lot of this stuff. We still have a tremendous number of people that don't have health insurance. And look how much money we've spent over the past couple of weeks bombing Iran. A fraction of that money could have addressed all of this kind of stuff. We have real folks, especially with the wealth disparity within this country, people that are hungry, people that are homeless, all of this stuff. And these folks, if they aren't depressed, they are extremely in need of depressed. And very, very often they can't even access mental health professionals to deal with their issues, because a lot of their issues are triggered by things that aren't going to be changed by talking or by medication.
Medication. Yep.
True. So
Agreed.
true. Now, Dr. Aluya, I know we're over time, but we're going to keep going because Dr. Duncan, there's a last question out that came up that I wanted to get with you with. But Dr. Aluya, go ahead.
So, just like Dr. Duncan said, and Dr. Spratt really alluded to it, two things: context, who, where, how, and what. Who's been affected? How's this person affected? What's affecting this individual? And what's the outcome? You know? And the next one is resilience. Do we have the tools that helped our generations or generations before us build resilience? We're losing a lot of that. Our community strength, the societal, communal relationships that we've had. We're losing a lot of all this stuff. And like they say, when in the absence of, in the presence of poverty, people go tribal. What that means is when there's scarcity, people don't have as much anymore to share. Everybody go on to identify, hold on to things that will give them the most succor or strength. And that's what's happening. The whole of societies are falling apart.
Mm-hmm.
And priorities are being placed in different areas. So for me, when somebody comes in to my office and has issue with anxiety, one, is this a new patient? Right, that's one context. Or is this somebody I already know? If it's somebody I already know, I know who this person is. I know what their prior life is and all because I've taken their history. So a lot of the time, sometimes I may even say, you know what? Let me give you a 0.5% of Xanax for just a week or 2 weeks. Come back and reassess, and we'll see how things are. I've had times where I give somebody a month and I decrease the dose and I see them and I give them off time off work because it's an adjustment disorder with anxiety or depression. And I've seen that either because a new boss came on board and they're giving them stress and a new promotion and they failed to get the promotion, or the child is sick. All of these things, come into play. And you have to know how to address those issues and make it, appropriate. And sometimes they just need somebody to talk to. And that's why in medicine we have what they call the worry well diagnosis, Z71.1, right? The person is worrying well, but they're just worried about, I may have a disease or some cousin had cancer. Now I think I have cancer, and they're constantly worrying. I see that all the time. Now, if it's a new patient and comes in and said, Doc, I think I have anxiety. Okay, you have anxiety. Walk me through what makes you think you have anxiety. It's an open-ended question. Then they'll walk you through. You see through what the whole issue. Oh, I've been taking Xanax 0.5 or 1 milligram 2 times a day, clonazepam. You know exactly where this is going, and you know how to redirect them. So that's how I approach these things when they come to the office.
Excellent, excellent. There's a question here, Dr. Duncan, that and before we end, I'd just like to address it. And I think this comes under the realm of where you're going to be for many, many years. It says, Dr. Duncan, can you speak on the impact of legalization of recreational cannabis and the extremely high THC levels that have been normalized in the wake of this being legalized?
Okay.
Can you kind of give us some broadening of this on from your perspective?
Sure. So first off, with regards to legalization, and I will say the positive first. Legalization is a plus in that we know historically those who are incarcerated for possession and/or selling happen to be of color, Black and brown people. That's a plus. The issue is that, marijuana now is not my grandparents' marijuana or, no offense, but you guys' marijuana. The marijuana now and the concentration of it is at such a level where risk of things. So let's talk about adults first. Is just a correlation. The higher level of THC that you have, which is the psychotropic active compound in marijuana, the higher level of potential mental health issues. And this would include things like, first and foremost, psychosis. The amount of times that I see patients that come to my ED or to the inpatient unit because of just the definition of psychosis secondary to substance use disorder is a problem. Additionally, because you have it is legalized and you now have these dispensaries, it's super expensive. So who are the individuals who cannot afford this dispensary weed? is usually people of color. So they're now getting it from drug dealers, they're getting it on the street, and it is not, you can't guarantee what's in it. So now there's another risk of them now smoking other chemicals as well. So that's adults. If you look at kids, there is an issue with regard to children smoking marijuana because you also see a correlation of increase in things like anxiety, depression, and also more severe things like schizophrenia that you can see in children as well. It's a problem. It cannot be shown as like this very safe thing because that's not the case. And it really is something that, you know, if it's done recreationally, it should be done in a very responsible way. But there is a very dark side or dangerous side to it. And I see it every day.
Yeah, yeah. I think we're
So,
adjusting.
Doctor, so I'll tell you this. And you alluded to it, Dr. Duncan. Look, the marijuana that baby boomers smoked when in the 1960s was about 1 to 4% THC. Today, it's 17 to 30%. And there's a huge difference because some people are so smart and they grow these things in specialized manner and in controlled rooms where they have the ability to increase the THC component of it. And then you have others who in vapes are really highly concentrated to the point they get up to 90% concentration in vapes. So these are issues, and that's why, like you said, it's not safe. So, but the question is this: what are the rules? What are the regulations that the government needs to put in place? And how would our society and you and I, as doctors, and our communities, and our medical associations, coming to impress on the government, local, state, or federal level, on how to regulate these things? Because we can't allow them just go haywire. Because at the end of it all, we will bear the brunt of it. If there's indiscriminate use of THC in this case, in oils, in all the other things that we see. So it's something that needs to be looked into, and we need to learn to protect and preserve our communities so that we don't lose our children.
Yeah, yeah. Thank you, thank you. Excellent. We're going to do this. There was another question that came up, and I'm going to answer this last question because I think it's just important, and it's one that I don't have the answer for, and hopefully somebody can give us some guidance for it. I just want to ask this question concerning prostate. It states, if a prostate is slightly enlarged, can it return back to normal with modification of lifestyle, or must this person take medication? That's a question. Yeah, yeah, I'm not sure. Uh, you know, Dr. Aluya, do you have any?
Yeah, so one of the things you see of lately, I think about 5, 7 years ago, the American Urology Association came up with rules for people not to do the PSA anymore. You understand? Because they were having too many false positives. But then when I looked at the literature, I looked at everything else, and in our community, especially those who are Black, we tend to have a higher incidence of prostate cancer, and not just high incidence, but more aggressive prostate cancer. And one of the things that people don't understand, that if there's a history of breast cancer in the family, you as a man in that family has about 8 to 12% chance of having prostate cancer if there's a female in your family with breast cancer, and vice versa too. So if there's prostate cancer in your family, the females in the community has up to 12 to 16% chance of having breast cancer. So we need to know, and all of these things are coming out now. Now, in terms of prostate enlargement, it's a natural process. Maybe it's the food or whatever. But one of the things that I begin to really understand, and hopefully I'll write about it, I'll publish about it, when I see somebody's prostate PSA enlarges, a lot of the time I ask them any issue, because if you look at the urine, some people have what they call cystitis or asymptomatic pyuria. Now, if that is not treated, it increases the risk of an enlargement of the prostate, right? Because they're right around there. So what I've done lately, I just treat them first. I give them a 5 to 10 days course of Cipro, and I check the level again. My God, I've been doing it for about a year now. Hopefully, I'll do. The number drops. It drops. I keep still checking it 3 months, 6 months subsequently, but then it comes. But if it drops and then you begin to see it rise again, then you need to say, you know what, you repeat 3 months, 6 months, and then refer to a urologist. So that then you can, and before the urologist, you can actually get an ultrasound to look at the prostate and see if it's really a diffuse enlargement or there's a unique swelling or node or whatever, in it. And then they go on to do a PSA with a biopsy, and then the stuff goes off from there. So it's something we need to pay attention to. And those of us who are black, especially black urologists and doctors, we need to come up with something that really push the narrative within our community so that we can preserve our community, really.
Yeah. I excellent. Well, this has been one I think great and extraordinary webinar. We covered a lot of topics, answered a lot of questions, and boy, I'm just so proud of all you physicians that come and take the time to put this webinar together. So, oh boy, let me do my closing remarks because we definitely went over just a few minutes, just 1 or 2 minutes. All righty. In closing, number one, thank you, OBHealthy, for allowing us to bring this to you because, boy, I just appreciate them sticking with us all these years and helping us put this Zoom webinar together. Note that it's every second Saturday at 1 o'clock, and please, it takes a village, so let everybody know about it. It's called Caring and Sharing, so if you really care about others, then let them know about the webinar that it's happening so they can come and increase their knowledge about their medical condition. Please do not change any aspect of your medical care until you consult your physician. Only your doctor, truly, only your doctor can best take care of you from a medical perspective. All right. If you want to see our past webinars, it's on YouTube. All you have to do is go to the website, OBHealthy, hit the camera, or hit our YouTube sign, and all of our past webinars come up. There's so many topics, and please go and educate yourself. I look forward to seeing everybody next month. Don't miss it. Second Saturday, 1 o'clock. Join us next month, please. All right. The only last thing I'm going to say is do me a favor and spread the word. All righty. Until next month, I'm going to say peace and thank you to each and every one of the physicians that came on today to bestow the knowledge to all of our public out there. Thank you. All right. Again, peace, everybody. We'll see you next month.
All right.
Peace.
Bye bye.
Take care.
Take care. See you.